Picture this. You are sitting at your desk, chart open, looking at the labs and imaging for your next patient. They are a 45-year-old adult, completely asymptomatic. I mean, they feel entirely fine. They are in your clinic for routine follow-up, but they do have several metabolic risk factors.
Right, the classic presentation we see every day.
Exactly. Their BMI is 32, their A1C is creeping up into the pre-diabetic range, and their lipid panel is just less than stellar. So as part of a thorough workup, you ordered a transient elastography to check their liver health, and the stiffness measurement just came back at something like 11.5 kilopascal.
And it is flagged right there in bright, bold red ink on the electronic medical record.
It is. There is something deeply psychological about seeing that red number. It practically screams at you to take immediate action. And for the vast majority of practicing clinicians today, the reflex reaction is to immediately generate a referral for a liver biopsy.
It is the absolute natural reflex in modern clinical practice. And frankly, it is a byproduct of how we are trained to react to abnormal diagnostic data. Transient elastography is an incredibly seductive technology.
Seductive because it is so easy, right?
Exactly. It is quick, it is performed right there in the clinic or imaging center, and it is entirely non-invasive. You get a concrete number. Because the liver biopsy remains the undisputed diagnostic gold standard for staging liver disease, acting on that high elastography number feels like the most prudent, medically, legally protective thing you can do.
You just want to be safe.
You want to be safe. You want to avoid missing advanced bridging fibrosis or, in the worst case scenario, compensated cirrhosis in a patient who currently looks and feels perfectly healthy.
But if we just sit on our hands with an elevated stiffness, aren't we doing the patient a massive disservice? I mean, if they actually have compensated cirrhosis and we ignore that red flag, we are completely missing the window for hepatocellular carcinoma screening or variceal surveillance.
That anxiety is real.
The anxiety of missing that window is exactly what drives the referral. But there is a massive clinical paradox sitting right in the middle of this workflow. Despite how universally we relied on these scans, there's actually no validated liver stiffness threshold for biopsy referral in this specific asymptomatic population with metabolic risk factors.
None. And that is the core issue that forces a complete reevaluation of how we manage these patients. In an asymptomatic adult with metabolic risk, there is no single scientifically validated cutoff number on an elastography scan that automatically dictates a liver biopsy is necessary.
We really have to move away from treating that stiffness number as an absolute truth.
We do. It is a surrogate marker. We love numbers in medicine because they offer cognitive offloading. They make a highly complex biological process feel linear, predictable, and manageable.
We treat the elastography score like a straightforward check engine light on a car dashboard. You see the light turn on, and you assume the engine has severe, irreversible structural damage.
Which is a terrible analogy for human physiology.
Right. So today, we are taking a close look into why relying on a single elastography number is actually a clinical trap. We need to navigate how to safely manage this diagnostic gray area, look at the hidden physiological factors that drive that number up without any actual scarring, and firmly establish when you actually should break out the biopsy needle.
The fundamental flaw in our clinical instinct is the assumption that a high number automatically equates to advanced disease. That assumption falls apart the moment you realize that stiffness is not exclusively a measure of fibrosis.
Because other things make the liver stiff?
Precisely. Fibrosis, the actual scarring, the collagen deposition in the hepatic extracellular matrix, absolutely does make the liver stiff. But it is not the only physical property that alters tissue elasticity. If you treat stiffness and fibrosis as perfectly synonymous, you are going to mismanage the patient, subject them to unnecessary procedures, and completely misinterpret the pathology.
This means we need to establish a new default clinical posture for daily practice. The baseline recommendation is simply this. Do not routinely refer for a liver biopsy based solely on a liver stiffness measurement.
Yeah, for just the one number.
If that isolated kilopascal reading is the only thing driving your referral, hit the pause button. While it is true that stiffness correlates well with advanced fibrosis in broad populations, there is zero direct evidence that a biopsy triggered only by this single number improves patient outcomes in this specific asymptomatic group.
We have to seriously weigh the risks here. A liver biopsy is not some benign, risk-free intervention. We're talking about genuine risks of subcapsular hematomas, severe pain, infection, biliary leak, and tremendous patient anxiety.
Just the waiting alone is incredibly stressful for the patient.
It is. Furthermore, even the gold standard has flaws. A biopsy samples roughly 1/50,000th of the total liver volume. The sampling error alone means there is up to a 20% discordance rate in staging.
20% is huge.
It is significant. If we are going to expose an asymptomatic patient to those physical risks and diagnostic limitations, we need to be absolutely certain it is justified by more than just a single unvalidated data point from a machine.
It fundamentally comes down to diagnostic stewardship. We are trying to find the patients who truly need intervention without catching hundreds of others in a net of over-medicalization. So if fibrosis isn't the only thing driving that stiffness measurement up, we have to look closely at the confounders. We know the number is high, but if the liver isn't filled with collagen and scar tissue, what is actually happening physically inside that organ to give us that elevated reading?
Patient context is absolutely everything here. We have to look at the specific physiological factors that fundamentally alter the reading. Let's start with obesity,
Which is incredibly common.
almost ubiquitous in this specific demographic of metabolic risk patients. Obesity directly increases the risk of unreliable measurements. The physical presence of subcutaneous adipose tissue fundamentally alters the way the mechanical shear waves propagate during the scan. Fat attenuates the wave.
The physical medium the scan is traveling through is entirely different. The machine sends a mechanical pulse, and it has to travel through a thick layer of fat before it even hits the liver capsule,
And the machine tries to compensate for that acoustic attenuation.
which frequently leads to artifactually high stiffness readings or just a completely indeterminate result where the machine fails to get a clean reading at all.
Exactly. When you are scanning a patient with a high body mass index, your interpretation of that number has to be heavily adjusted. You cannot use the standard thresholds. In many cases, you have to ensure the technologist is using an XL probe.
Right, the one specifically calibrated for deeper tissue penetration.
Yes, but even then, the false positive rate is higher. You might need to pivot to entirely alternative non-invasive testing methods, like magnetic resonance elastography, which isn't hindered by the same acoustic windows because the standard ultrasound-based measurement is structurally compromised by the body habitus.
Another massive confounder that mimics scarring is inflammation. Whether it is an acute flare-up of a chronic inflammatory liver condition, acute viral hepatitis, or cholestasis.
Inflammation is a huge trickster here.
It really is. If you think about what inflammation actually does to tissue on a cellular level, it causes severe swelling, edema, and cellular infiltration. It physically stretches glicin's capsule, the fibrous layer surrounding the liver.
It is essentially the water balloon effect. The liver becomes tight and stiff, much like a water balloon filled to the absolute bursting point. The elastography machine reads that physical capsular tension as high stiffness.
But that isn't scarring.
No, that is just acute swelling. If you immediately biopsy that patient based on the high number, the pathologist might just report active lobular inflammation without any of the advanced structural fibrosis you are hunting for. It is a classic falsely elevated stiffness reading driven by hemodynamics and edema, not collagen.
It measures tension, not just scar tissue. And it is not just primary hepatic issues that cause this tension. Systemic hemodynamics play a huge role. If we look at cardiac issues, right-sided heart failure can completely mimic cirrhosis in the stiffness readings.
Because elevated central venous pressure transmits retrogradely.
Right directly down the inferior vena cava and into the hepatic veins.
The liver essentially becomes a sponge congested with backed up venous blood. The sinusoids dilate and become engorged. Again, the organ becomes physically hard and pulsatile,
So the scan will show a severely elevated number.
often well into the cirrhotic range, but the primary pathology is purely cardiac. If you don't look at the patient's jugular venous distension or their lower extremity edema, you will completely misinterpret that high kilopascal reading as advanced liver disease.
Beyond patient physiology, the obesity, the inflammation, the cardiac congestion, we have to look at the equipment itself. There are significant technical variables that clinicians frequently overlook.
You mean the difference between machines?
Exactly. A reading on a FibroScan, which uses vibration-controlled transient elastography, is not on the exact same scale as point shear wave elastography or two-dimensional shear wave elastography on a standard ultrasound rig.
The specific elastography modality and even the specific manufacturer's probe type inherently alters the stiffness values. You cannot treat a number generated by one modality as perfectly interchangeable with a number generated by another.
A cutoff of 8 kilopascals might be highly suggestive of significant fibrosis on one machine.
but might fall into a completely indeterminate gray zone on a newer two-dimensional shear wave setup. Clinicians must apply modality-specific interpretation rather than making blanket assumptions across all imaging reports.
Given all these confounders, the acoustic attenuation of fat, the capsular stretch of inflammation, venous congestion, and equipment variance, we really have to change how we interact with these reports. We need strict operational rules for managing asymptomatic metabolic patients. Let's run through a rapid-fire breakdown of what not to do.
The absolute rules.
Yes. For one, we have to stop treating a single stiffness value as a definitive fibrosis stage.
It is a screening and risk stratification tool, full stop. You cannot write stage 4 fibrosis or cirrhosis in a patient's chart based purely on an elastography number without biopsy or glaring clinical confirmation.
That leads directly to the next critical boundary, abandoning universal cutoffs.
You cannot use a rigid, universally applied threshold for every patient that walks through the door. You must actively adjust your interpretation for the patient's body mass index, the specific probe type used, and their current transaminase levels to account for inflammation.
Relying on a single rigid number willfully ignores the physiological reality of the patient sitting in the exam room.
Exactly.
We also can't fall into the reverse trap. A low stiffness number does not give us a free pass to ignore glaring clinical signs. Just as we have false positives from inflammation and congestion, we have false negatives.
Letting a low number talk you out of high clinical suspicion is a dangerous diagnostic error.
If a patient has multiple strong clinical indicators of advanced liver disease, maybe they have spider angiomas, palmar erythema, or a rock-hard nodular liver edge on physical exam, you do not dismiss those findings just because the elastography machine spit out a reassuringly low number.
Never ignore your physical exam.
Yeah.
We also have to be highly aware of the epidemiological trap. You cannot take stiffness thresholds that were derived from studies on highly symptomatic populations or mixed populations in tertiary hepatology centers and blindly apply them to this highly specific group of asymptomatic primary care adults with metabolic risk.
The predictive values change drastically depending on the prevalence of the disease in the population you are studying. A cutoff that has a fantastic positive predictive value in a transplant clinic where prevalence is high will have an abysmal positive predictive value in a general outpatient clinic where prevalence is low.
You will end up drowning in false positives if you borrow data from one clinical group and force it onto another.
And finally, before you even look at the final stiffness measurement on the report, you must evaluate the technical quality and reliability of the scan itself.
You should be looking at the interquartile range to median ratio. If that ratio is over 30%, or if the patient wasn't properly fasting before the scan because postprandial blood flow increases liver stiffness, the number is garbage.
If the reliability parameters are poor, the measurement is entirely meaningless.
Completely meaningless.
So we have a firm watch and wait baseline, and we know the traps. But let's be realistic. Medicine is never one size fits all, and watch and wait does not mean ignore and neglect. We have to know exactly when to pivot.
We do.
When do we actually pull the trigger and order the liver biopsy for an asymptomatic metabolic patient?
We must remain highly vigilant for specific clinical pivot points. The first scenario where you break the rule is in the event of technical failure.
So if the measurement is unreliable due to severe obesity, or an obvious mismatch where the standard probe was used instead of the XL probe,
Do not base your clinical decisions on that flawed data. You don't just guess. You drop the tool, but you don't drop the workup. You repeat the measurement with the appropriate technique, or you pivot to alternative non-invasive testing modalities, like magnetic resonance elastography, that are less affected by body habitus.
what about an acute transaminase flare? If we have an asymptomatic patient whose elastography is suddenly sky high, but their AST and ALT are sitting at 400, we're likely looking at that water balloon effect. Acute liver inflammation is causing a false elevation in stiffness.
In that case, you deviate by deliberately deferring the biopsy. You do not rush in with the needle while the liver is actively inflamed and mimicking fibrosis.
You just wait.
You wait, you monitor the patient, allow the acute inflammatory episode to resolve, wait for the transaminases to normalize, and then you repeat the scan. You must let the swelling go down before you attempt to measure the scarring.
But what if we are dealing with extreme values? If I get a scan back and the stiffness is 25 kilopascals, I am not going to sit on my hands and wait for next year's follow-up.
No, you shouldn't. Very high, extreme stiffness values absolutely warrant a referral, but with the caveat that the extreme value must be verified
It must be confirmed by multiple different testing methods.
and deeply supported by the clinical context. If the number is genuinely off the charts and everything else in the clinical picture aligns, a biopsy is justified to confirm the severity and architecture of the disease. You don't ignore massive outliers, but you verify them before acting.
Which brings us to what modern hepatology is demanding we do anyway, the multimodal approach. This is where we combine the physical stiffness score with biochemical serum markers.
We are talking about calculating a FEB4 score using age, AST, ALT, and platelets, or running an enhanced liver fibrosis test.
If the elastography is high, the FAB4 is a 3.5, and the platelets are sitting at 110,000, we have a consensus.
The chorus is singing the same song. When a mechanical test and a biochemical test collectively point in the exact same direction, strongly suggesting advanced fibrosis, then a biopsy should absolutely be considered.
It is no longer an isolated, unvalidated number driving the decision.
It is a convergence of concordant data. That convergence gives you the diagnostic confidence to proceed with an invasive procedure.
And finally, the most obvious pivot point is clinical deterioration. We are discussing an asymptomatic population. But if you are monitoring this patient and they suddenly develop new clinical signs, if you see their platelet count steadily dropping over 6 months, or you palpate new onset splenomegaly, or they develop spider neva.
That watch and wait posture goes right out the window.
Completely.
The rules change instantly. In the face of new symptoms highly suggestive of disease progression, chordal hypertension, or decompensation, you must reassess immediately. A biopsy then becomes a critical, urgent part of a comprehensive evaluation to figure out exactly what is failing in that patient's liver architecture.
To synthesize this entire discussion into a core framework for your daily practice, in asymptomatic adults with metabolic risk factors, you must treat liver stiffness as just one single piece of a much broader clinical assessment. Default to clinical observation and risk factor modification.
You only refer for that liver biopsy when multiple concordant clinical and non-invasive indicators strongly suggest advanced fibrosis, and only after you have rigorously ensured the elastography scan itself is technically reliable and free of confounders.
Adopting this cautious, balanced approach heavily prioritizes patient safety.
It does. The strict evidence around specific numerical cutoffs in this population is weak, but we have a high degree of confidence in this multimodal strategy. It relies entirely on your skill as a clinician to monitor subtle biochemical and clinical changes over time, rather than demanding immediate reflexive action based on an isolated machine-generated data point.
It puts the art of medicine, the pathophysiology, and clinical judgment back in the driver's seat. Before you head back into clinic or open your next patient chart, I want you to mull over this final thought. If we are firmly moving into an era where we can no longer rely on a single, clean, non-invasive threshold to automatically trigger interventions in metabolic liver disease, how might our very criteria for what constitutes an asymptomatic patient need to evolve? As our ability to monitor these subtle subclinical biochemical changes improves, the line between silent risk and active disease is going to become increasingly blurred.